Good morning. So today, 3rd of May, we are going to look at a checklist for critical appraisal. And Reba has put a lot of effort into this. Today we're looking at Spirit AI. Spirit is a checklist for writing a protocol for the research committee or IRB, as people call it. And she is taking the Spirit is meant for randomized controlled trials. So Reba has taken an extension of Spirit called Spirit AI, where one arm of the randomized controlled trial involves AI as part of the arm. So it's a protocol for a study in which one arm is an AI, or part of the arm at least is an AI. So without further ado, Reba.
Good morning, everyone. Today we'll be looking at the critical appraisal of an AI trial protocol using the Spirit AI checklist. So we'll start off with the clinical scenario. You are in charge of the pediatric asthma clinic, which is held in the afternoon on Monday, Tuesday, and Friday. You have one consultant and 2 registrars to man the clinic. Typically, 30 children are seen per day. Due to shortage of registrars in the general pediatrics, one of the registrars gets suddenly pulled back from your specialty OPD. Now you are left with a dilemma. Should I reduce the OPD cutoff to 20 per day, or should I not reduce the cutoff? If I reduce the OPD cutoff to 20 per day, there are some repercussions. That can be a result of backlog of cases which need medical attention. So you're actually depriving the student of care. Second thing is also loss of income to your department. Suppose I don't reduce the cutoff, we're having very shortage of doctors, so they can easily get burnt out. So as you're pondering, you get a phone call from your long-lost college friend who happens to work as a respiratory physician in Mayo Clinic. He tells you how they have used an AI application which helps them to see the patients quickly and make faster decisions. So you suddenly become interested and you wonder if you could implement this and would it help our doctors and our patients so that the clinic can run smoothly without compromising care. If you look at how AI systems can be used in health, you can use it for triaging patients, for diagnosing patients, for prognostication, as well as to help you make decisions. That's called decision support. It can also be used for treatment. Today, the article which we will be appraising is the Artificial Intelligence Assisted Clinical Decision Support for Childhood Asthma Management, a randomized trial study. If you look at what are the checklists which actually exist to appraise AI trials, you have the Spirit AI checklist, which is basically an extension of the Spirit checklist for protocol guidance. And you have the Consort AI checklist, which helps you report the AI trials. Today, we'll be concentrating only on the Spirit AI checklist to look at how well they have developed the protocol. And briefly, we'll just run through the RCT using the TAFs guidelines. So this is the protocol. The principal investigator was Dr. Young, and the study title was Enhancing Asthma Care and Outcome through the Implementation of Asthma Guidance and Prediction System on Asthma Management Program, a randomized block design. So the first version was drafted in 2015. So if you look at this first trial protocol, they have subsequently had 7 revisions to it. And you have the final trial protocol published in 2020. And some outcome measures also they had changed in the final publication. But however, in the final version of the RCT, they have only uploaded the first protocol version. So we'll be appraising only the first available version. So the first domain in your Spirit AI checklist is administrative information. The first item is title. So it's very important that the title is actually understood by everybody. The title should clearly indicate that this is an AI trial or it includes some machine learning. Why is it useful? Because it will help you later when you want to actually find this trial through bibliography and for indexing also. So if you look at this trial, the title for the protocol, it says Enhancing Asthma Care and Outcome through the Implementation of Asthma Guidance and Prediction System. It doesn't really tell you if this is an AI or not. But however, the final RCT, they have nicely labeled it Artificial Intelligence Assisted Clinical Decision Support for Childhood Asthma Management. So the protocol title is not really great. Second thing, it doesn't really tell you what part of asthma does the protocol, does this AI system help you in? Does it help you in diagnosing? Does it help you in treatment? Or does it help you in making a clinical decision? The second thing is, trial identifier and registry name is not yet registered name of the intended registry. So this was not actually written in the protocol. They had not told whether they're going to publish it in the which trial registry, but they have published it in the clinicaltrials.gov identifier, and this is the identifier for the same. And the protocol version has been told us it's version 1 and it's published in 2015. The next part of your administrative part is your funding and roles and responsibilities. However, in this protocol, they're not really told who's the funding funder and they're not really told the individual responsibilities of the authors. But in the final RCT, they have mentioned that the funding is from Innovative Methods to Improve Asthma Disease Management Program, Genentech, and National Institute of Health, funded R01 grant and R21 grant. Next, we go on to the introduction. So the introduction basically it includes the background and rationale as well as the objectives and the trial design. So the extension is explain the intended use of AI intervention in the context of the clinical pathway, including its purpose and its intended users. For example, is it for the healthcare professionals or is it for the patients or is it for the public? And the second part is describe any pre-existing evidence of the AI intervention. So I'll just give you a brief background of their justification for using this asthma guidance prediction system. First is, they felt that there were a lot of significant number of children with asthma, and they experienced delays in diagnosis, approximately around 3.3 years, during which time their care and outcomes were often overlooked. The first thing was there was a delayed diagnosis for early intervention and missed opportunity for early intervention. Second is, although they have good care coordination programs, basically they have multidisciplinary management for asthma, they felt that they could not apply it to a wider population. It was only meant for a small population. So they want to build something which they can apply to a bigger population. Third thing is, they were underutilizing the potential of an electronic health record. Now most of the hospitals have electronic health record, but however, we don't really have an application to extract what the physician has written as well as structured fields, and they can actually use it to make real-time management. Fourth thing is there's importance for prediction. For precision medicines. So if you actually look at it's not one shoe fits all. You have to look at each person, each risk factor. So you can actually look at each child, see what risk factors they have, whether you can modify those risk factors, then your treatment for the child will also improve. Then fourth, the last one is improving asthma outcomes and reducing healthcare costs. So they feel like if you have a system which will help in earlier diagnosis, proactive risk mitigation, and data-informed management, you can actually reduce the number of asthma exacerbation rates and prevent hospitalizations and associated costs. So how is AI changing the future of precision medicines? In this study, it helps you in real-time monitoring of the patient health. It also helps you in early detection of asthma cases. So now what is this asthma guidance and prediction system? So basically, it's got three important things. It provides you a high level of relevant clinical information. Basically, looks at your electronic health record. It applies the natural language processing capabilities, and that reads through all your reports over every timeline and gives you a summarized clinical information of the patient. Second thing, it also uses a machine learning based predictive analytics. It uses the naive based probability system to actually predict whether the patient is at a high risk for asthma exacerbation, low risk for asthma exacerbation. And the third thing is it gives you asthma management options to help the clinicians make efficient decisions. So how do they design this? So first, the design phase, they had advisory input. So they've called the many primary caregivers and they've asked them in what way they want the tool to help them. So they have actually looked at the NAEP 2007 guidelines. So they have focused on 32 variables which will actually help them with improved asthma management. They have done this by doing focus group assessment as well as surveys. And the physicians have also prioritized what they want. So these are some of the variables they wanted information on. That is asthma outcomes, asthma care quality, as well as modified risk factors and unmodifiable risk factors. So some variables under asthma outcome will be the number of emergency department visits, unscheduled OPD visits, how many wheezing episodes the patient had, and what is their current asthma control. That is by using an asthma control test And what is the current pulmonary function test? That is basically the FEV1 and the spirometry test. Things which will actually help us assess the asthma care quality is like what's the severity of asthma? Is there a history of asthma care? Where did specialists give the asthma care? Do we have any status of the allergens or triggers of smoking available? Has the patient been educated on inhaler technique? Has the patient had any spirometry test? Some of the modifiable risk factors which they looked at were, did the patient have any known triggers for allergy? Was there any smoking exposure present? What is the asthma medication adherence? Did the child get an influenza vaccine? Was there any history of allergic rhinitis or depression or obesity? Some of the unmodifiable risk factors which the physicians wanted data on was the socioeconomic status, which they found with the help of House's index. And what about air pollution? So they wanted to know the child was living in a hotspot for high traffic volume. So for the development part, they had two system modules. One is the natural language processing, and the other one was the NICE-based machine learning model, the prediction module. They used 5 variables, basically previous asthma exacerbation, whether the patient was actually symptomatic, the number of hospital visits, use of rescue medication and control of medication to predict the asthma severity. So the data source would be from electronic health records, free text clinical notes, socioeconomic indicators like the House's index, as well as geospatial environmental data, example, the traffic pollution risk. And they validated by using, so what they did was, for 2 years, they looked at how the AI, the application had captured the information, and they manually checked it. So they found the sensitivity was around 88%, specificity was around 99%. And they felt that it had actually good predictive performance with an AUC of 0.74 in the cohort, as well as 0.78 on the validation cohort. So this is the final output which the system gives you. So if you look on the top left, it gives you the quality of care. For example, when was asthma first diagnosed? 2013. And what is the current status? So it's moderate persistent asthma as of January 2017. And what care has the child got? Child has got a pulmonology consult in 2016. What they have not yet assessed is the inhalation technique is undocumented, whether the child is properly using the inhalation technique or not. Was any recent spirometry done? The last spirometry done for this child was more than 3 years. And the last updated asthma action plan has been for more than 1 year. Then they also looked at the risk factors for this particular child. So for this child, they already know that this triggers were trees and grass. Child has allergic rhinitis or atopic dermatitis. Child is also obese. And some of the things which a child cannot modify is the child belongs to a lower SES, and the child is living in a high traffic volume area. Then they looked at the outcomes. So the flags basically tell you unscheduled asthma visits. So the child had an unscheduled asthma visit around September 2014 and one around March 2015 and one recently around September 2016. Child was not present with wheezing. This plus sign basically tells you the FEV1. So the FEV1 around November 2014 was around 85, and in August was around 90%. The triangles basically tell the asthma control score. So around February 2014, asthma control score is around 17. We actually want to be more than 18. In November 2020, it was 25. Recently, the control score is only 19. And with all this, it gives you finally a risk of asthma exacerbation. So this child is at a high risk of an asthma exacerbation. So then it also gives you what options you can do in terms of interventions. Either you don't change the asthma care, or you refer this child to a pediatric asthma coordination program. You address risk factors through the asthma coordination program. Or you can refer this child to a community health worker. You can recommend an allergy test. You can recommend a spirometry. Then you can also recommend an asthma specific regular visit, like every 3 to 6 months, you can ask the child to come. So these are some of the management which you can do for the child. So how do they implement it? So they deployed it in the Mayo Clinic's pediatric asthma care setting. The study design was a RCT, with children divided into 3 blocks. So the reports were delivered quarterly to the primary care physicians who could adjust the asthma care plan and be finally implemented by the nurse care coordinator. So now we'll move on to the objectives as well as the trial design. So the objectives which are mentioned in the protocol is, First is to develop and implement a system on the current asthma care by identifying children with persistent asthma through the electronic health search. So the hypothesis was it's actually logistically feasible. The second aim was to assess the primary endpoints between the intervention control group by conducting a RCT with a block design. And the hypothesis was children enrolled in the intervention group have improved primary endpoints compared to the control group. I'll come to what the primary and the secondary endpoints were. So this is the trial design. It was a single center, pragmatic, single-blinded randomized clinical trial with a block design. So the block one were patients who were persistent asthmatics, and they were aged 5 to 17 years. They were already enrolled in the Mayo's asthma management program. That means they already were getting intensive care. The block two were persistent asthmatics who were not yet enrolled in the Mayo's care coordination program. They were aged 0 to 17 years. Block 3 were children who had asthma-like symptoms, but they have never been formally diagnosed with asthma. And how do they use, how do they classify patients in the block 3 as asthmatics were? If they satisfy this predetermined asthma criteria, that is, the child should have any history of cough with wheezing or dyspnea, or the child should have a history of cough and dyspnea plus wheezing on examination. There should be substantial variability in symptoms from time to time or periods of weeks or more when the symptoms are absent. And the child could have 2 or more of the following: either sleep disturbance because of nocturnal cough or wheeze, nasal polyps, that eosinophilia more than 300. If the child had all three, child was told to have asthma. The child had any two, was a probable asthma. So the next one is, so describe the on-site and off-site requirements needed to integrate the AI intervention into the trial setting. So the setting was in the Mayo Clinic Pediatric Practice, Olmsted County, Minnesota. It's important to know that this county is actually, the healthcare is extremely good. There are only 2 hospitals which cover the entire population. One is Mayo Clinic, which covers 2/3 of the population. The remaining 1/3 treatment is given by the Olmsted Medical Center. So they have data about almost every child in that county. So they have around 2,000 children with asthma. 385 children are less than 5 years. 1,754 children are 5 to 17 years of age. Out of this, 376 children are already in the part of the AMP care coordination program at the Mayo Clinic. And the eligibility criteria is the child's age is 5 to 17 years, child has persistent asthma, and is taking medical care in the Mayo practice. This is the Mayo Clinic, it's in the Rochester city. So the on-site and off-site requirement is not really explicitly mentioned in the protocol, but once you read the protocol, you will figure out that you need all these. So at the trial site, you need a good clinical infrastructure. You should have a dedicated clinical practice, like a pediatric practice. You need to have computers and devices with secure data environment. You also need to have access to these electronic health record, which can actually process your structured as well as unstructured clinical data. You also need personal training, like you need to have clinicians who are trained. For example, faculty, residents, fellows, who can interpret this asthma report and update plans based on the recommendations. You need to have nurses or coordinators to implement your plans. And if possible, you can have clinical assistants who can actually administer these asthma control test scores on the patient to see how whether they're symptom free or not. And you also need the AI to work. So you should have software modules or dashboards where doctors can access the AI reports. And you should also have reminder systems to inform the doctor to access that report. What are the offsite requirements? You need to have some people who can actually help you with the AI. For example, data scientists and your informatics team who can update and monitor your NLP algorithms. You should also have a secure server to protect the patient data. Then you need to have your IT to troubleshoot any problems. Then you must also have external audits who can evaluate your AI performance and safety monitoring. So next is the inclusion exclusion criteria at the level of participants and the inclusion and exclusion criteria at the level of the input data. So if you look at the level of participants for block 1, the children should be aged 5 to 17 years. They're diagnosed with persistent asthma and they're already enrolled in the asthma management program. Children with persistent asthma not enrolled in AMPS will come under block 2. So these are children who are aged 0 to 17 years. We must have either a physician diagnosis of persistent asthma, or they should have such an evidence based on the use of controlled medications, like they're using inhaled corticosteroids, which are prescribed in the past 12 months. And they should not be enrolled in the AMP. Third is children who have recurrent asthma-like symptoms without asthma diagnosis. So these are children aged 0 to 17 years. They must have recurrent asthma-like symptoms in the past 3 years. They've not been documented to have asthma in medical records, but however, they fulfill that predetermined asthma criteria, which I had shown in the previous slide. But the general requirements across all blocks are they should be residents in this Olmsted County in Minnesota. They should be receiving care at Mayo Clinic practice, and they should all of them should give consent. So what is persistent asthma? So if you look at the headers criteria, basically emergency department visits or hospitalizations for asthma during the past 12 months, or based on the National Asthma Education and Prevention Program criteria, more than 2 exacerbations requiring steroids within the past 6 months for children less than 4 years, or more than 2 admissions for children more than 5 years within the past 1 year. So what is the exclusion criteria? One is children on immunosuppression, plus children for block 3, for them to diagnose an asthma, if there are some confounding diseases. Like for example, if the child has some tracheobronchial foreign body aspiration, child has some bullous emphysema, or an alpha-1 antitrypsin deficiency or cystic fibrosis, you can't really diagnose a child as asthma because she has other coexisting conditions. At the level of data, so you need to have an electronic health record data for the previous 3 years. Then only it will show you the trajectory. Second thing, you can have both. You need to have structured data, like for example, ICD codes. What are the medicines the child is taking? Unstructured data will be what physicians write when they see the patient, like symptoms, like what we write in a normal EMR history examination. They also need socioeconomic data, which they got from the houses index, and they need environmental data. And they also need the asthma control scores. So data level exclusion is if the child has insufficient electronic health record history, like less than 3 years, or there is incomplete asthma control score data also was excluded. There's no exclusion based on other comorbidities. So this Mayo actually has its own SES program, wherein all the patients under their care, they can calculate something called houses index, which tells them the individual SES at the time of interest. It gives you area deprivation index, like based on where they're living, it can tell whether the patient is at a socioeconomic disadvantage or not. So to track your asthma control, we have a couple of scores. So the asthma control test, this is for children who are more than 12 years. On the right side is for children who are the age of 4 to 11 years. So parents can actually fill up the form with the help of the child's input. And this is for children who are less than 4 years. So a track less than 80 is good, or a act for more than 17 is good. So now we move on to the interventions. So state which version of the AI algorithm will be used. The second one is specify the procedure for acquiring and selecting the input data for the AI intervention. Third is procedure for assessing and handling poor quality or unavailable input data. The fourth one is there any human AI interaction in the handling of the input data and what level of expertise is required for users? Fifth one is what was the output of the AI intervention, which we already covered. Sixth one is explain the procedure for how the AI intervention's output will contribute to decision making or other elements of clinical practice. So the algorithm type which they have used is the naive Bayes classifier, which is a simple probabilistic machine learning model. This is not the same as deep neural networks, which basically the model itself can keep learning. Next, we have a training data. So they looked at retrospective data from 590 pediatric asthma patients at the Mayo Clinic. The training set was 300 patients for the model development. And for validation, they used 290 patients. So they used the 5 variables, that is previous exacerbation history, the asthma symptoms, the hospital visits, rescue medication use, as well as control of medication use, to predict whether the child is at a high risk or a low risk for asthma. And they found that the area under the curve was 0.74 in the training set and 0.78 in the validation set. So basically, this is a supervised machine learning algorithm. It's called naive because it assumes that each input is independent from each other on the effect. So for each risk factor, it calculates the probability and it combines to give you the overall at the end of the Okay, so what were the variables which they have collected for the asthma risk factors? So for risk factors, they looked at the gender, the race, the family history of asthma, the atopic conditions. For asthma outcomes, they have looked at the asthma control test, as well as the TRAT score, the number of outpatient visits with asthma code, ED visits or hospitalization with an asthma code, in the frequency of exacerbation of asthma requiring systemic corticosteroids. So quality of care is how many of the children in block 2 were enrolled in the asthma management program? How many children in block 3 ended up having a physician diagnosis of asthma? How many children ended up having an influenza vaccination? Or was there any documentation of an asthma care after the child is coming to an ED? Were appropriate medications given for people with asthma? They've also looked at cost, like the average expenditure for an asthma care per member per month, and the total cost of healthcare per member per month. So from all these data, the primary care physicians had actually given them priorities, saying high priority should be information on household smoking exposures, houses, hotspot for high traffic volume, or hospitalization for asthma in the past. For priority 2, they felt that ED visits for asthma, family history of asthma, other atopic conditions were important. Less among the priority 3 was probably the documentation of asthma medication adherence, enrollment of asthma management program, pets at home. So this is all based on what the physicians in that setting decided. And for most of these variables, they could actually get it itself from the electronic health records using the NLP. So we covered this. So now we move on to the outcomes, the participant timing, and the sample size and recruitment. So here the primary outcomes which they have mentioned is a total duration of good asthma control, that is an ACT score of more than 90. The second primary outcome was timely care and response of asthma-related events. The third outcome was physician diagnosis of asthma, that is for the patients in block 3. And the fourth was the total cost per member. But actually, in the protocol, if you look at the protocol itself, what they have written as the first one was the number of ED visits, hospitalization for asthma, or unscheduled visit. Basically, they have in the protocol they mentioned that the primary outcome is number of asthma exacerbations. But however, they have given a flow diagram where if you look over here, the primary endpoint is a total duration of good asthma control. So I think they made a small mistake in the text. And in the secondary endpoint, they have written the number of ED visits, and the second is enrollment in an asthma management program. Third is influenza vaccination. Fourth is discussion of asthma care during general medical examination. But what I want to stress is, by the time they have reached the 8th modification of the protocol, and when they published the RCT itself, the primary outcome changed to this, which is the number of ED visits or hospitalization for asthma or unscheduled visits. So this is the overview. So they have put the children in 3 blocks, and in each block they're randomized to the control arm and the intervention arm. And they look at the child, the endpoint at the baseline, as well as the endpoints at the end of 12 months. And afterwards, they will continue the GPS program for all children. Okay, so how do they calculate sample size? So in the protocol, they calculated sample size, assuming that the primary endpoint is total duration of good asthma control. That is ACT score more than 19 or TRAC score less than 18. So from previous studies, they have found that children with persistent asthma had about 9.5 symptom-free days per 2-week period. That is 70% of time and estimated standard deviation of 2.6 days. That means in a year, 8.4 months, they would not be having asthma. So what they assumed was that the duration of good asthma control for children in various blocks would be around maybe 9 months, 8.4 months, and 10 months. So they felt that if they assign 50 children to the block and 50 children to the treatment group, they will have around 80% reduction of this. So they will have 80% power. It's okay. So they will, if the sample size is 50 children per block, that is 50 in the control arm, 50 in the intervention arm, you would have an 80% power to detect the corresponding difference of around 7 to 11%. So they felt that the asthma-free months would increase to 10 months, 9 months, and 11 months respectively. And for the next outcome, that is for a timely care in response to asthma-related events. Suppose a patient had come to the emergency department, and then further follow-up would be around 7 days for block 1, 30 days for children in block 2, and 90 days for children in block 3. They felt that after this intervention, the differences would reduce to around 6 days, 28 days, and 85 days for post-exacerbation follow-up. The next thing is, for physicians who, in block 3 patients, how many of the children actually ended up having a physician diagnosis? Right now, they had pilot data which showed that 64% of those children who met that asthma criteria did not have a physician diagnosis. So they felt that after doing this study, that odds ratio would increase from 0.29 to around, it would decrease from 0.56 to 0.29. Then for the next part, that is the total healthcare cost per member. They felt that the current cost is around for block 1, block 2, block 3 is around $136, $150, and $120. And they felt that after this intervention, there'll be decrease around 5%. That means the patient will be spending $129, $142, and $114. So how do they go about recruiting these children? So first, they will look at the Mayo Clinic pediatric practice, and they will look at the patient medical records and screen eligible candidates. Then they will contact the parents and guardians by using a telephone. And so they will speak to them on the telephone and explain to them about the project. And if the parents are okay and they would give a verbal consent, then they will give them a formal letter. And in the back of the letter, there would be a area for them to sign. So then the parents would have to fill out the letter and send it within 2 weeks. If the parents did, they will be getting reminders either by telephone or by emails or texts. So who actually recruited the children? There's somebody called Dr. John, who is actually the pediatric asthma epidemiology research unit. He's actually specialist, and most of the Mayo asthma clinics, he only has recruited most of the children. And the head of the asthma management program is somebody called Ms. Joy Green. So next question is, how did they generate the sequence for randomization, and was the allocation concealment mentioned or not? So here, this is what they have mentioned in the trial protocol. The gist of it is, within each block, 100 children will be selected, 50 will be assigned to intervention group and 50 to control group. And the randomization will be stratified based on the gender as well as the age groups. But they have not mentioned how the random sequence is generated. Like, did they use a computer sequence, or did they use any other methods? And they not clearly mentioned about the allocation concealment. However, in the final trial, they have written that children are assigned to intervention or comparison groups by using computer generated sequential random numbers. So next thing is blinding. So who will be blinded after assignments? So here only the children and parents were blinded. The primary care physicians were not blinded because of the nature of the intervention. Like, you can't really blind the primary care physician because some of them will get the reports. For some patients, they do not get reports. However, they could have blinded the outcome assessors, like the physicians in the emergency department were treating asthma patients. The investigators also should have been blinded. Next is the data collection method. So how do they collect the data? So, number of ED visits and hospitalization, this can be actually collected by using electronic health records, and also the ICD codes for asthma exacerbation. And they can also use the CPT code. Basically, CPT code is basically the insurance codes. So for office ED visits or hospitalization. And if they have been prescribed any drugs, they will come under the national drug codes. For asthma control status, it's based on the quarterly questionnaires over 12-month period. We've already gone through the questionnaire, that is asthma control test as well as a track score. And they also gave feedbacks by emails and phones. For influenza vaccination, they retrieved this based from their electronic health records as well as the CPT code for influenza vaccination. For environmental exposure data, they actually got help from the Rochester Public Works Department, which would tell them the traffic at each neighborhood. So how do they actually validate whether this worked or not? They did a manual chart review to validate this performance, and they found that it had good sensitivity and specificity. Now, whether any plans to promote the participant retention and complete follow-up. So the asthma care coordinator, the care team, or the study coordinator will contact the patient over the phone, mail, or online ACT questionnaire with a reminding system using the phone, email, or text message. So basically, the parents didn't fill up the questionnaire; they would be getting reminders. So that will actually help the patients in prolonged follow-up. And one more thing is, looks like they have given some sort of an incentive, because in that verbal transcript, they have written, as a token of appreciation upon completion of the study, we will send you a total of $20 or $5. So this could be an incentive. Now the next part is, how do they manage the data? So was there any plans and provisions made for data entry, coding, security, and storage? So they have this in quite a bit of detail they have given. So each participant was assigned a unique study identifier, and all personal identifiers like name, address, social security number were not used in the data analysis or reporting. Then the identifiers were destroyed at the end of the study, and all reports were aggregated and de-identified. And the study data were all stored securely, either in electronically password protected database or they were physically kept in locked file cabinets. And only authorized personnel like the investigators and study coordinators had access to the data set. And data queries and analysis were conducted using systems with access logs to track usage and ensure compliance. So what was the statistical principle they used? They used an intention to treat analysis. Meaning even if there was loss to follow, they would look at whether the child was actually enrolled into the which arm. Third thing, the next thing is what did they do with the missing data? So here, they have considered all whatever is missing as missing completely at random. They not really cross-checked it. They not done any imputation analysis to see if this is actually true or not. They have just assumed everyone is missing at random and expected them all to have minimal impact on the outcome validity. So these are some of the statistical methods they have used for analyzing the primary and the secondary endpoints. So for the primary endpoints, the number of ED visits, they've calculated the incidence. They've used ANOVA test for continuous outcomes, logistic regression applied for binary outcomes. And in the secondary endpoint, they have again used ANOVA to look at the proportion of events per person in months. And they've used binary variables by using the chi-square and logistic regression. So the next part is what about data monitoring? Did they have a data monitoring committee or not? So in this protocol, they have mentioned that they did not have a data safety monitoring board because they felt that the intervention they're doing is not harmful to the patient. They're not getting any new treatment or anything. They're just giving information. And the study followed the Mayo Clinic's safety protocol for clinical trials. And what they mentioned is the study investigator, that is Dr. Young, he oversaw the study progress with support from the asthma care coordinator and the project data analyst, as well as members of the care team. So this group kept acting as an internal monitoring panel, ensuring data integrity and safety oversight throughout the trial. But actually, as an investigator, you should not be looking at the study data till the trial gets over. So I don't think this is justified. They should have had an independent board to actually look at whether the results are safe or not. Next is, did they have any interim analysis? So they did have an interim analysis which they conducted 6 months, basically to see if the quality control was there and whether the protocol is being whether there was protocol compliance. They have not really accounted for this in the sample size. However, the results were not used to stop the study because they felt it was a non-invasive nature of the intervention. So next thing is harms. Whether any plans to identify and analyze performance errors. If there are no plans for this, justify why not. So here in the entire protocol when I went through, there was no formal performance error analysis framework. But they have used manual validation. They have done some interim reviews. They've also looked at, they've done a structural team oversight, which is involving the principal investigator. And they also have some feedback mechanism. So hopefully, if there was any harm, it will be picked up by using these other methods. Next one, we come to the ethics and dissemination. So was there ethics approval? So yes, they had actually submitted this protocol to the IRB. There were no plans for communicating. So were there any plans for communicating important protocol modifications to relevant parties? For example, investigators, IRB, trial participants, trial registries, journals, regulators. They not mention that in the protocol, but however, as I told you in the beginning, they have put up all those modified protocols in the registry. Yeah, so whether there's any consent, who will obtain informed consent or assent from potential trial participants? They're not really mentioned, but I'm assuming it's those people who actually recruited the patient would have got the informed consent. And do you need any additional consents for biological specimens? Here it doesn't involve any biological specimens, so it's not applicable. So what about confidentiality? How personal information will be protected? As I've already covered that all the clinical data will be kept in locked files. They would have unique study numbers. And even the patients who email their correspondence, after they extract the ACT and track score, they will delete their emails. So whether any declaration of interest, they have not mentioned anything about financial and other competing interests for principal investigators. So the next question is access to data. State whether the AI intervention and its code can be accessed. So they have not given any plan for sharing the AI tool or its code with external researchers. Most likely because it's within the Mayo Clinic itself, unless you have a collaboration with the Mayo hospital, maybe they can share the code with us. What about ancillary and post-trial care? They have not specifically included any provisions for ancillary and post-trial care. but I'm assuming that they will continue this EGPS for all the patients once the trial gets over. What about dissemination policy? Whether they'll communicate the trial results to participants or other healthcare professionals, it's not mentioned in this protocol. Authorship eligibility guidelines are also not mentioned. And whether any plans for granting public access to the full protocol, participant level data set and statistical code. So it's not mentioned, and they have not really released the participant level data set or statistical code. And appendix is also has an informed consent been attached? They have partly attached it. They have given us a transcript of the verbal consent, not the official consent. There's no need for any biological specimens. So this is the verbal consent script which they would call the patients. So what I have used is actually the 2019 Spirit AI protocol. Just 5 days back, the new there's an updated guideline for the existing Spirit checklist. So the things which they have added is in item 11, they have added items on how patients and public are involved in the design, conduct, and reporting of the trial, where the patient's feedback used. In this study, it was not used. They have used only the primary caregivers' feedback. Second thing, they have added items on trial monitoring, which replaces prior item on auditing. Other revised content was item 4 is they were also asked to include the date of the trial registration. Item 5 is whether the statistical analysis plan can be accessed in addition to the trial protocol. So here in our protocol, it was already mentioned what analysis they're going to do. Item 7B is revised item to include financial and other conflicts of interest of steering committee members, which is not there in our protocol. Then item 25 is basically they'll the blinding itself they will split into who will be blinded, how, and revised to include description of the similarity of interventions. Item 27 would cover sensitivity analysis. Some things which they have deleted was on auditing they have deleted and replaced with trial monitoring. They have deleted the appendix items like whether informed consent was deleted as well as biological specimen was deleted. And the other important thing is they have actually emphasized harm that they have taken from the Comfort AI checklist also, which actually the AI trial is supposed to in detail discuss about harm. They have included that in the Spirit AI protocol. In our study, they not really mentioned anything about harms because overall they felt there were no harms in my trial. What the trial people have also done is they have reported their own protocol by using the consort checklist. But you should know that they have not done the consort AI checklist. They have only done the 2010 consort checklist for any RCT. So now that we finished the protocol, I'll just quickly run through the RCT to see if there's any changes. So they have published this RCT. The objective in this one, we can see the difference, is to assess the effectiveness and efficiency of the asthma guidance and prediction system and artificial intelligence assisted clinical decision support tool in optimizing asthma management. So is the basic study design valid for randomized controlled trials? Yes. This is the PICOT statement. So we have population less than 18 years, diagnosed with persistent asthma, receiving care at the study site. Intervention is giving them quarterly AGPS report to clinicians, including relevant clinical information for asthma management. Control would be usual care. Outcomes would be primary endpoint is occurrence of asthma exacerbation within 1 year. Secondary outcome would be time required for clinicians to review electronic health records for asthma management. So this is a new secondary outcome. That means clinician time to look at the document. And the time would be 1 year. So the study design, it's a single center pragmatic RCT, stratified randomization design. The study period was from 2016 to 2017. It was registered at the clinic trial registration, and the IRB number they have actually put in the RCT is very different from the protocol they have actually published. So this is how the flowchart would happen. In the intervention arm, in the first 3 months they would get a report. Second 3 months they would get another report. Third 3 months they would get a report. You should understand that the physicians were not sitting in front of the patient when they got the report. All the reports would be given at one particular point of time. They would just look at the chart and they would make a care plan. So was the assignment of participants to the interventions randomized? Yes. So here they have mentioned that they have used computer generated randomization. So probably the allocation sequence was concealed. Where all participants were encountered the study accounted for its conclusion? No. So if you look at the comfort checklist they had given, it's very incomplete. So they had actually wanted 300 participants, 100 in each block. So if you look, finally they have got only total of 184 out of the 300 they had intended to recruit. And the loss to follow-up is actually 7% is mentioned in the article. But we don't know where the loss to follow-up was. Was it from the intervention group? Was it from the control group? From which state it was lost? We have no idea. So section B is was study methodologically sound. So they have done blinding of the children and family, but not the primary care physicians, and investigators and outcome assessors will also not blinded. Were the study group similar at the start of the randomized control trial? Yes. If you look at all the age as well as the gender, most of it is matched. Only thing which I felt it was not matched was the seasonal influenza vaccine, which was given more for patients with control arm. That will probably reduce the amount of asthma exacerbations. Next thing is family history of asthma, which was more in the intervention arm. This is also non-modifiable risk factor. Apart from the experimental intervention, did each study group receive the same level of care? So both study groups received the usual asthma care, only the AGPS report differed. Okay, so the statistical part, here they have mentioned a different statistical plan. So here they have defined as primary endpoint of hospitalization ED visits related to asthma is around 59.2%, 50.6% when you treat them for an asthma exacerbation. So if you assume that the baseline prevalence rate of hospitalizations and ED visits were 30.4% and 63.6% respectively, and that the percentage decrease in the control group by 10%, we would have an 80% power and a two-sided alpha level of 0.05. So they would need 100 subjects, each for the intervention as well as the control group. So in our study, they have not reached the sample size. So the study population was well defined. The outcomes were well defined. Randomization was done. Allocation consignment probably done. Clinicians were not blinded. The sample size calculation was adequate, but the sample size was not adequate. Intention to treat analysis was done, and baseline characteristics mostly was matched.
So allocation consignment should have probably done.
Probably done. So section C, what are the results? So the results were, if you look at the left side, on the y-axis is the percentage of the children with acute exacerbations. And on the x-axis, the first box is intervention arm and the second box is control. Orange is pre-trial and blue is post-trial. So the percentage of children with AE decreased from almost 17% to 12% in the intervention arm, 25% to 15% in the control arm, but the reduction was not significant. So the AE frequency in the two groups, 12% for the intervention arm versus 15% for the control arm, and the odds ratio was 0.82 and the 95% confidence interval was 0.34 to 1.96. So it was 1. So it was not significant. The other things I noticed from this trial were there were more interventions being done in the intervention arm. So, for example, those primary care providers, they were more proactive in the children who got the APS reports. So they referred them to the asthma management program, 18 in this arm and 7 in control arm. They referred them to community health workers, 5 in the intervention arm, 0 in the control arm. They requested for allergic skin tests, 8 in the intervention arm and 5 in the control arm. More spirometries were ordered for the intervention group, 23 versus 12. And they also had regular visits for the children in the intervention arm, like 33 compared to the control of 4. And even the asthma control test update was, they updated 28 patients in the intervention arm and only 7 in the control arm. So the primary outcome, there was no difference. But looking at the secondary outcome, that is the clinician's time in minutes taken to make clinical decisions. So in the intervention arm, it took them only 3.5 minutes to actually make a decision. But if they did the routine other evaluation, they took around 11.3 minutes, and this was significant. The other thing they looked at was healthcare costs. They have not looked at every single healthcare cost. They only looked at the direct medical cost. For example, if the child came with asthma, how much would that cost? So they assumed that in the post-intervention group, there would be a decrease. So if you actually see from pre to post-intervention in the intervention arm, there was the cost actually decreased by $1,036. And in the control group, it went up by $80. But however, this was not statistically significant. So were the effects of the intervention report comprehensive? So they have given us the p-values, they have given us the confidence intervals. However, it was not significant. So next question is, do the benefits of the experimental intervention outweigh the harms and costs? If you look at it from the healthcare perspective, I would say yes. Next thing is, will the results help locally? can the result be applied to a local population? So I thought they had looked at good outcomes. They had looked at the exacerbation rates. They had looked at the electronic health record review times. They had also looked at the healthcare costs and asthma control. These are all important outcomes. Next thing is, they could have done it. They could have done a cost benefit analysis from the healthcare provider point of view. So, for example, if you look at this graph, our new intervention is actually more effective in terms of the chart review. Okay, so I would probably put it on the right side because the clinical time has come down. But is it more expensive? I don't know the cost, how much it took to actually develop the AI. Probably it's more expensive. But overall outcome seems to favor the AI rather than the usual care group, but it's not statistically significant. So maybe around this quadrant. That is the lower bottom quadrant. So are there any outcomes you would have wanted information on that have not been studied? So the changes which I would make to the GPS if I want to apply to our care is, I would rather have the GPS being displayed every time the patient comes for a visit rather than quarterly, so that we can make a real-time change of care plan for the patient. And the second thing is, I thought it would be more practical if we actually included the medications also. What medication the child is on and what is the prior medication change. So we can actually quickly prescribe new medicines if we need instead of again reviewing the chart. And I thought in our setting, we actually have all these requirements. We have good clinical infrastructure. We have enough personnel to implement it. And we have a good IT system also to help us. So overall, coming back to our clinical scenario, so this dilemma, whether would I reduce the OPD cutoff or will I not reduce the OPD cutoff? I think I would not reduce the OPD cutoff and I try to implement this prediction system at the time of review visit, and I would train more nurse coordinators so that they can implement the care plan.